Hello, everybody. Thank you so much for being here. We still have some people trickling in, so we are going to get started here, but we're going to do a little bit of introduction so that hopefully we get a couple more people to join us. But first of all, I just want to say thank you so much for joining us today for our first Tuesday talk. We are very excited that you're here and about the series that we are launching. My name is Maddie. I work here at Genesis with the team, and we are just going to do some short introductions, kind of give you an overview of what we're going to talk about today, and then feel free during the whole talk. There is a Q&A button. I believe it is on the bottom. It might be on a side. If you just click on that, if you enter your questions, we will answer those at the end, and we'll let the four providers answer those at the end. So with that being said, let's go ahead and kick it off. So we are Genesis Spine Joint and Regenerative Medicine. We are located in Federal Way, Washington. We started as the Pain Center of Western Washington about almost 20 years ago, and then we moved locations, and then we changed our names a couple years ago. So you might have heard of us or heard us in the past as the Pain Center of Western Washington, but we are now known as Genesis Spine Joint and Regenerative Medicine. And our team is made up of 4 providers. So today we have joining us Dr. David Velling, Dr. Russell Kinder, and then our 2 PAs, Michelle Scott and Jonathan. If we could go to the next slide, that would be great. Perfect. Okay, so Dr. Velling and Dr. Kinder are both double board certified in anesthesiology as well as pain medicine. Dr. Velling opened the practice, like I mentioned, almost 20 years ago and has been a medical director since that time. And Dr. Kinder has over 10 years of practicing pain management, but he just recently joined the team in January, so we're very excited to have him. And then both Michelle and Jonathan joined us last year and have different backgrounds and different specialties, and we are very glad to have them on the team as well. So I'm going to have them introduce themselves and say a little bit about themselves and maybe their approach to patient care, and just give a little welcome. So let's go ahead and start with Dr. Velling.
Thank you, Maddie. I just wanted to welcome all of you to our webinar. Hopefully this is something that'll be educational for all of you. I've been in practice here in Federal Way for about 18 years. I've been in the state of Washington for a little over 20 years. And so as time has gone on, we've tried to evolve and offer different things with this practice to be able to help people with their chronic pain problems. We try to see as many patients as we can in a timely manner. The bulk of our practice is treating patients with low back and neck pain, but we also see a lot of people and treat a lot of people with joint problems, neuropathy, other things like that. So we tend to take a interventional approach with minimally invasive procedures. So we've expanded the practice over the last year. So we are, try and get people in as quickly as possible, because nobody likes being in pain, and we want to see people as quickly as possible. So anyway, I'm going to pass it on to Dr. Kinder, who just recently joined us. Let him say a few words about himself, and we'll move on.
Hello, everybody. I'm Dr. Kinder. Like Dr. Velling said, I'm the newest provider on staff. I just started at the beginning of the year, and it's been great so far. A lot of the patients that are listening may have been around with the practice a lot longer than I have been, and can probably tell you how great their experiences have been. I've been really excited to join this practice that has a big emphasis on putting the patient first, and making sure that we're prioritizing the right things for patients. So I think it's going to be a good long-term fit for me. So I'm really excited to be here. A little bit more about my background other than my credentials. I'm born and raised Washingtonian. Eastern Washington is what you guys call it. When I was born there, we called it Central Washington. And did most of my medical training here in Seattle, and med school out in Chicago. But really glad to be back here in Seattle and helping out our community here. I've been interested in helping people with chronic pain since I was in middle school, and had some close family friends that had been going through a lot of challenges dealing with chronic pain. And I just feel blessed every day that I get to work with people and try to help them through their challenges of dealing with chronic pain. I really try to always see things through the patient's perspective. And I think as long as you have your heart in the right place and you try to do the right things, it can be a very satisfying relationship, and had a lot of good outcomes helping people find a better station in life. And that's about it for me.
Great. Thank you, Dr. Kinder. Michelle, why don't you give us a little intro of yourself, and then you can pass it off to Jonathan, and he'll take it from there.
All right. Well, I'm Michelle. I'm one of the physician assistants that works here. A little bit about my background is that I started my career in medicine in radiology. I worked as a radiology tech for approximately 14 years before deciding to go back to school and joining the ranks of the PAs. I do have a military background, which I think that kind of leads to my ability to kind of put the patient first and always put the mission first, so to speak. My philosophy on healthcare is always listening to the patient, giving them a safe space to tell me what's going on and to determine how I can help them in the best way possible. I'm going to go ahead and kick it on over to Jonathan.
All right. Well, so far you guys have met the rest of the team, and I know that a lot of our patients have met me, but my name is Jonathan. I'm the other physician assistant here. So I basically am originally born and raised in New Orleans, Louisiana, and then I moved up here because job opportunities were better. And I have been very fortunate to be a part of this team, and I really enjoy getting to meet everybody. And in terms of the way I practice, I try to make it so that everyone is comfortable sharing what their pains are or what their concerns are. And I always try to help address every question as I possibly can, and try to help individualize everyone's pain management treatment plans to what they need, and not necessarily just like a big one algorithm that just one size fits all everything. So that being said, let's actually go ahead and get started. So does your back pain prevent you from enjoying any of these things? Being able to just, do basic functions of living around the house, like such as washing dishes, or being able to go to work and really be productive and not be in pain all the time. Or maybe you have some children, some little grandchildren that are like maybe 1 or 2 years old that you want to be able to chase around without being in pain. Or even doing outdoor activities such as hiking. We have a lot of patients who like to travel a lot, go on road trips. Or we also have a lot of patients who like to do gardening, painting, things like that. And every now and then we get asked about being sexually active. And yes, that's a real question that people ask. And yes, it is a real concern. So that is something that we wanted to address today. But a lot of these activities are things that are often hindered because of any kind of low back pain. And there's different types of low back pain. So it's not like a one size fit all kind of umbrella here. So today we're going to kind of talk about 3 main different types of back pain that, and these are the most common ones that we see in our practice here. So one is shooting low back pain, one is aching low back pain, and then the last one is like just the low back and buttock kind of pain that you kind of feel when you're sitting down. So I just wanted to quickly go over some of the low back anatomy that if you've met me, I like to use my models a lot. So one way I wanted to kind of show you is kind of give you a basic run through of some of the anatomy that we're always looking at to make sure that we can help you out. So hopefully you guys can see my pointer, but basically the blue parts here are the discs in between each of your vertebrae. And then this is basically the whole lumbar spine area. So this is what we consider your low back. So we have 1, 2, 3, 4, 5, and then here is your S1. Your S1 is basically your tailbone. And on other models, you'll see sometimes like yellow things coming out the sides. Those represent your nerve roots. But in our talk, what we'll be focusing on are a lot of the facet joints, which are kind of here in between each of your vertebrae. And we'll be focusing on some of the disc and some of the nerve compression that can occur from that. We'll also be focusing a little bit on our sacroiliac joint, which is basically the joint that is where your tailbone essentially meets your pelvis. So that's going to be at those spots right there. So low back pain causes, like I said, there's multiple causes, and these are just some of the most common ones. Just because we don't talk about it today doesn't necessarily mean that there's not some other type of low back pain out there. But like I said, these are the most common ones. So it's going to be lumbar radiculopathy, which was formerly known as sciatica, lumbar facet joint syndrome, post-laminectomy syndrome, or this used to be known as failed back surgery pain syndrome, and SI joint pain. So let's start off with lumbar radiculopathy. I know it's a big word. It's a lot of people often get scared by this term, but all it means that you have shooting nerve pain due to some sort of nerve irritation or some sort of inflammation. And you got to ask yourself, okay, what's making the nerve so inflamed and irritated? A lot of times it's often from an abnormal disc. And that's where if we have if we refer back to that model, in between each of your bones, you have a disc, and that disc is kind of like a shock absorber for your spine. So oftentimes, if you think of it kind of like a jelly donut, if you keep pressing and pressing and pressing down on it, sometimes if the jelly pops out, you get a herniated disc, and that herniated disc can press onto the nerve roots that come out the side of your back. And a lot of times that can also cause what's called some nerve stenosis. And that's where the nerves themselves get a little bit squeezed and impinged upon. So those are the main causes. Like I said, you'll feel like shooting nerve pain, numbness, tingling, and pins and needles sensation. And what you'll often see is that we'll try to get some imaging to substantiate what we see on physical exams. So with imaging, that can be an X-ray, and a CT, or an MRI. But usually on those, it'll show some sort of disc bulge or herniation. You can see some central spinal canal stenosis, neuroforaminal stenosis, or nerve impingement. A lot of these are really big words, and I know that, but I just wanted to at least introduce those terms to you, so that way if you ever see them on like an MRI that maybe your primary care doctor had ordered, you're like, oh, I actually understand some of these words. And then some of these are the treatments that we can do here. So for example, we can do epidural steroid injections, and there's different approaches. So we can do a lumbar approach where we can do basically in between two levels of your lumbar vertebrae. So if we go back to the image before, so it would be kind of like in here, in here, or in here, or in there, or in there. We can also do a caudal approach, which is basically going through the tailbone area, and underneath the tailbone, there's actually quite a few nerve roots that come out under there. So sometimes that can help control the pain, and in that instance, in that distribution that goes down your legs. And as well with the caudal, the medicine does spread up a little bit into this area as well. And then a transforaminal approach, which is kind of like what some of my patients might be familiar when I describe it. I kind of call it like a sniper approach, because we're going in on the sides here in between where the nerve roots come out. And that's where we can maybe target like a specific level that's going down the leg, or if there's a specific nerve distribution that we see that we want to treat. However, though, sometimes these epidural steroid injections, maybe it's not working for you as much, or if in some cases there's some contraindications where maybe the patient can't receive a steroid safely. So other treatment options include a spinal cord stimulator trial. And basically I've had it described a couple times as like, it's like a TENS unit for your spinal cord. And what it can do is it can emit some electrical pulses that will help block pain signals from wherever you're feeling the pain. And this would be nerve and neuropathic pain from going to your brain. And you sort of can help control and modulate that type of pain response that you get. And then one of the things that we don't do here, but that often do sometimes help with this low back pain is we refer patients to physical therapy. Physical therapy with a directed lumbar stabilization program can sometimes really work wonders for patients. And that all these different treatments are things that we can do here and help you out in terms of figuring out, okay, is this really nerve pain that's really bothering you? So, and moving on, we have more like aching pain now. So this is more like mechanical aching, maybe stabbing pain that you feel when you maybe just get up out of bed, you try to like do a stretch and then all of a sudden, oh snap, that really, really hurts. Or if you're trying to twist and turn in a car and you're driving and you all of a sudden feel like, oh, that hurts a lot, like someone's about to stab me or really, really pinch or grab at your back. So this type of mechanical aching and stabbing pain, it's usually due to facet joint syndrome. And what facet joint syndrome is basically due to the arthritis that you feel. And just to go back to our model here, it's basically these joints here that connect each of the vertebrae from the top to the bottom to the next one. And over time, with overuse, or maybe it's from your job or something like that, we can see that a lot of inflammation happens at those joints. And the inflammation is basically causing all this arthritis. So sometimes on imaging, when we go ahead and order some like MRI or something, we might every now and then see like edema. Edema is basically fluid that is surrounding those joints. And when you see fluid, that usually means there's some sort of active inflammation going on that's really bothering you. And when you have this kind of active inflammation, it's not always just two things rubbing up against each other necessarily. You also have a lot of chemical inflammatory markers that get released into the region around it. So sometimes the muscles over it are going to feel really, really sore. And all of that just contributes to the whole kind of aching pain that you're feeling. So these are a lot of the treatments that we do. We actually do all these treatments here. And usually the way that we would treat it is with a medial branch block and a radiofrequency neurotomy, also known as a radiofrequency ablation. For lack of better terms, basically what the radiofrequency neurotomy / ablation is that we're going in and cauterizing the little tiny medial branch nerves that innervate and sense the pain signals from those facet joints. It's safe because what we're doing is we're gently heating it up, and basically it kind of kills itself. And the thing is, the nerves do grow back over time, so it's not a permanent solution. They sometimes last between 6 to 12 months. Some people are really lucky and get like 2 years out of it. But the point is that the nerves do grow back, but during that time, that 6 to 12 months, you can get really good pain relief and go back to being able to at least drive and twist and turn without having to be in pain. In order to get to the radiofrequency ablation, insurances usually require us to do medial branch blocks. What these are is basically the exact same, almost the exact same procedure, but instead of going in and gently heating up the nerve, we go in and we numb the nerve first with some medication. And basically for 6 hours afterwards, we ask you just kind of let us know how you're doing. Every 30 minutes or so, you check off, oh, is this helping me? Anywhere between 100 to 0%. And essentially the block will wear off. It's supposed to be temporary, but it's supposed to be diagnostic for us to help us determine two things. One, are we in the right location? And two, are you even reacting to this kind of treatment? Is it helpful? So these two sort of go together. And then and the newer kid on the block is regenerative medicine. And these are mostly in the form of what's called PRP injections. PRP stands for platelet-rich plasma. And essentially it's like we draw your blood we spin it down to the really good parts of your blood, and then we inject the good parts back into your damaged joints. And at those joints, it basically is like a big reset button on a video game. It tells the rest of your body, hey, you gotta come back here, you gotta fix this. And usually that can sometimes be a little bit better than like a steroid injection, for example. So PRP injections, you can do them for your back, but we tend to go forward with the medial branch box and the radiofrequency neurotomy first as the sort of standard treatment. But PRP injections are an option out there for you. So next is what's called post-laminectomy syndrome. It's basically if you've had a back surgery, some sort of major surgery with any kind of orthopedic or neurosurgeon spine surgeon. What it is that even though you've had the surgery, you still have pain afterwards. And that's quite common in a lot of patients we see. Over time, basically, you feel stiffness, some aching pain, maybe at the site or around the site where you had your surgery. And sometimes this pain can really cause some nerve pain to go down your legs, your hips, your buttocks. And that can really cause a lot of pain. So essentially, if you think of it, the symptoms present really similarly to the previous two conditions we talked about before, like with your nerve pain and then with kind of your aching pain as well. So this is all just caused due to joint, disc, and any kind of nerve dysfunction, just because you've been cut open and someone actually played around with you in the back. So one of the best treatments that is still fairly new, well, I wouldn't say fairly new, but over the last 50, 60 years or so has really gained speed and really is a good non-pharmacological. So what that means is without taking drugs every single day, is called spinal cord stimulator trial. I hinted at this a little bit earlier with the other treatment for lumbar radiculopathy, but this is actually the main indication for it is post-laminectomy syndrome. So this device was specifically mostly created at first for this condition. And with this condition, again, you go in, we put two leads, and then the electrical pulses kind of help block the pain signals. And we've had a lot of success. We have a lot of patients who come in and say, oh, wow, this really, really worked for me. And I was bedridden before, and now I'm able to go hiking up Mount Rainier. And I'm like, okay, well, I can't even hike it myself without this. So that's the thing. We've seen a lot of life-altering changes with patients who undergo this. And the way it works is that we do a 7-day trial here, and essentially nothing's permanent. So all of it, once you take it out, you just have the little tiny holes where the leads go through, and those even heal up pretty quickly too. And then if you do well with it after 1 week, it's like getting the keys to test drive the new Cadillac or Lamborghini or Maserati or whatever you like. And if it works out for you, great. We refer you to one of the spine surgeons in the region who do the permanent implants, and then we get you implanted, and that can sometimes help control a lot of your pain. So this is going to be actually its own separate talk, I believe, next at our next talk. So if you're interested to find out more about it, tune in for the next one. So the last main cause of low back pain that I wanted to talk to everybody about today is sacroiliac joint pain. This often presents really similarly to facet joint pain, and a lot of times patients have multifaceted low back pain, which basically includes all of the above of what we talked about. But basically, with our patients, we see a lot of patients who have pain when they're trying to get up from a chair, or when they're trying to climb upstairs and they notice like, oh, there's a lot of pain in the low back where they can't do it, or they need a cane, or they need someone to help them up. And all of this is because of the arthritis that's at the SI joints. And this is actually a really good model here in this background picture. So these are the SI joints, and they're kind of pointing to it for us. And over time, you might have some little bony ridges that develop, and that can sometimes cause you a lot of pain. And that can cause a lot of straining of the muscles that are attaching near it. So a lot of these muscles, like if you overuse them, and just like with any muscle in the body, you can get a little bit of tendonitis, and some of that inflammation can seep over and basically overlap with this kind of SI joint pain. We don't necessarily need imaging to confirm this diagnosis, but that is something we can diagnose with just a physical exam, just for having you come in to see one of us and doing a physical exam. We can do the different maneuvers we need to do, and we can figure out, is it SI joint pain? We often do like to get the x-rays on top of it, just so that we can help confirm that there really is arthritis there, or whether it's more of the tendonitis from the muscles. And the way we treat it is we treat it with all these different procedures that we do here as well. Again, these are non-pharmacological, so you don't really have to take any kind of drugs for them by mouth. So the main ones we do are the SI joint injections. So we can actually go into the joints themselves and inject some steroid medication into them. Steroid is an anti-inflammatory. So what are you trying to treat? You're trying to treat all the inflammation from the arthritis. You also have a radiofrequency neurotomy, which is basically, there's a lot of lateral branch nerves that go to the SI joints. And just like how we have the little tiny nerves that sense the pain in our lower back for lumbar facet joint syndrome, our SI joints also have the same, not the same, but very similar layouts. So those are nerves that we can ablate and gently heat up and kind of cauterize off as well. And that can help give you sometimes 6 to 12 months of pain relief. So sometimes we do the SI joint injections. They don't last maybe more than like 2 months or so. We would probably recommend trying the radiofrequency neurotomy, so that way we can get a little bit longer lasting pain relief. And then again, in these joints, we can do regenerative medicine and PRP injections. And that's, again, the procedure where we draw your blood, spin it down to the good parts, and inject it right back into those joints. And it's a big reset button for your body to come back here and say, hey, come back and fix all of this for us. But anyways, those are the main four reasons for low back pain that we see in our clinic. So just to kind of review again, lumbar radiculopathy, that's more of just some nerve related pain. We can help treat those most commonly with epidural steroid injections. If not, then a spinal cord stimulator is a good option. We have patients with facet joint syndrome, and that's causing that aching kind of twisty turning kind of pain. And we can do radiofrequency neurotomies for those. And then post-laminectomy syndrome, that's when you have that pain after your low back surgery. And that can really respond well to spinal cord stimulator trial again. And then SI joint pain, that's more or less from your arthritis in your SI joints. And those can usually be treated with steroid injections, or again, with radiofrequency neurotomy, where we go and kind of cauterize those peripheral nerves to help give you some longer lasting pain relief. But yeah, we see all sorts of low back pain. Like I said, by no means is this list all inclusive, because there's a lot of different things out there that you can really have low back pain for. And really the only way to tell is to not necessarily trust Dr. Google all the time, but just come in and see us. And with that being said, I'll put it back off to Maddie.
Great. Thank you so much, Jonathan. I'm gonna, can you jump back one slide? I'm gonna run through a couple questions that we received, and then let you guys answer them depending on, maybe let's default to Jonathan answering, and then if Dr. Kinder or Dr. Velling want to jump in, feel free. But one of the first questions is, given all of that information, how do you determine what the best option is for a patient?
Well, I guess I can start off with answering that. So one of the first steps that we do is looking at your history. What have you had before? Like, what kind of injury could have precipitated this? What's your occupation? That sometimes gives us good indication. But the most important thing is probably the physical exam. So for all of our new patients, we always prefer patients to come in and have an in-person physical exam, so we can really do all those maneuvers I was talking about in order to kind of figure out, okay, which fork in the road are we taking here? I'm not sure if anyone else wanted to add to that though.
I'll add to it. I think that it's important, and I would agree with Jonathan that a good history and physical is necessary, and a good physical, and also we rely a lot on imaging exams, which would be X-rays or MRIs or CT scans, and really just it's experience and knowing, what to look for and what kind of questions to ask of people to find out what their symptoms are. We find that a lot of people may have more than one of these types of problems. This is not a complete list either. So really, it's in some cases, or actually a lot of cases, it's going through a process of trying to figure out what is the most likely cause of the pain, and then possibly doing some additional testing or procedures and see how people respond. So there's really not a one size fits all type of evaluation or treatment with low back pain. We try and very much individualize it. Dr. Kinder, if you have anything else to add.
Well, I'd just like to say thank you, Jonathan, for your review. I thought it was very good. Those conditions that were talked about today are some of the most common things that we see and treat in our clinic. And like Dr. Velling was mentioning, it is also very common for us to not immediately know exactly which one of these things or something else is the primary cause. And sometimes it comes down to a little more investigation, a little more history, a little more physical exam to try to clarify the overall picture and prioritize what we think is most likely causing the pain. At the end of the day, it may be just taking the top two things we talked about today. It may end up that you do have some nerve pain issues that we can treat with epidural steroid injections or other therapies. But you also have some arthritis pain that's causing low back pain. And we try to prioritize it in a way, what can we do that's going to give us the most information about what's happening and what's causing your pain and what's limiting you. And if we start there, how much can we help that pain from that cause? And do we need to still look at some of the other things that might be going on that could be causing pain? So sometimes it's the road to get to the end where you're satisfied and your function improves. Sometimes that takes a few steps, and sometimes trying a few things to get that list of possibilities narrowed down. And I think both Jonathan and Dr. Velling mentioned that this list is not comprehensive. These 4 things we're talking about, these are kind of the things that rise to the top that we see the most frequently, the most people know about. But off the top of my head, I can come up with another half dozen conditions that cause severe low back pain, and that we have to sometimes go down different diagnostic pathways and treatment algorithms to finally get you to your ultimate goal. Another thing I wanted to just mention, something that all of our providers do a really good job of, is we want to be able to coordinate your care when it comes to your pain management. So if you're kind of on the fence thinking, maybe should I go talk to the surgeon first? Should I go talk to these guys first? We're always happy to help coordinate that care. And we're certainly all specialized in this field where we can identify concerns that would be something beyond what we would be able to do with some of these less invasive procedures that might indicate talking to a surgeon and seeing if surgery is an option. And we're always keeping that in the back of our mind as, hey, if all else fails, maybe we get a surgeon's opinion about other options that could be available. But we're always on the lookout for things that would be concerning to say, maybe you should, before we go down any of these other pathways, maybe we get an opinion from the surgeon first to make sure that we're not missing something. And I feel like for a patient, we can be that primary point of care and help coordinate all those aspects of their pain management.
That's great. That was another question we received was, kind of where do we start if someone has never sought care for a pain similar to what you guys have described. So what you've kind of said was you can start with us, and we're happy to disseminate and coordinate with your team if you have a primary care doctor. They can either refer you here. We don't require a referral, but that you can come see us. And if it needs more intervention, whether it's a surgeon or physical therapy or something like that. Am I hearing you correctly with that, Dr. Kinder?
Yeah.
And I just
Perfect,
wanted
okay.
to quickly piggyback off Dr. Kinder's idea really quick. When we refer to a surgeon, we're not referring you to get surgery necessarily. Like Dr. Kinder said, sometimes we just need that opinion, and sometimes that will lead us towards a different treatment path. So again, I just wanted to let people know we're not sending you to surgery to get surgery all the time. We're sending you to get an opinion to help us make a better choice and decision in regards to your care.
Great, thank you. That's a good clarification. We have another question. The question is, will long-term use of steroids cause any damage to the nerves at all?
So long-term steroids, it's not so much to nerves, but over time it can have systemic effects throughout your whole body. Generally, we don't recommend more than every 3 or 4 months per region of steroids, but in terms of the physiology, there's a lot of other aspects that come into play, like ultimately your kidneys could get affected, things like that. But Dr. Kinder, did you want to help add on to that?
No, nothing to add there.
Okay, perfect. Okay, one other question that just came in is about spinal cord stimulators. So like Jonathan mentioned, we are going to do, the next talk is going to be really diving deep into what this technology is and who it can help and what it can do. But this patient's question is, can a spinal cord stimulator help with multiple levels of spine pain? For example, if you have mid and low back pain, can a stimulator help both, or is it more localized to just one area?
I'll take that question if you're okay with it. So Nina, this is a really good question for us to have with one of our providers, to have a more in-depth conversation about it. But in general, I've had success with spinal cord stimulators and helping multiple different areas of pain. It's important to remember that spinal cord stimulators don't help all kinds of pain. For instance, arthritis pain, muscular pain, spinal cord stimulator would not be expected to help that. So if you have different areas of pain, but there's different reasons for that pain, it may take different types of therapies to help that pain. But for instance, for the low back, we typically implant the spinal cord stimulator in the thoracic spine region. And so it's fairly common that we have patients that we're primarily treating them for their maybe low back, leg symptoms, and we're placing the spinal cord stimulator at the thoracic area that can interfere with those signals on the way to the brain. But when we talk to the patient, they say, yeah, I got this achy pain off to the side of my thoracic area. We can't find anything on imaging. They're not a good surgical candidate for that. Maybe we tried epidural injections or other kinds of trigger point injections in that area, and it's just not helping. It is very reasonable to see if we could, during the trial phase of the spinal cord stimulator, and we'll talk more about this at next month's meeting, for us to try to put those leads in a position.
I think Dr. Kinder froze for a second, but I think he was trying to say you can put them in multiple.
Low back and leg symptoms in the thoracic spine is a separate issue that needs to be addressed separately.
So Dr. Kinder, you kind of froze for a second.
Okay, yeah, I'm sorry, my internet connection's going in and out. I don't know where I got cut off on, but
I think
in other
you
words,
were talking about the positioning of the leads, how you can help target multiple areas of pain with it.
yeah. So your example of a person who has low back, maybe leg symptoms, and also has thoracic pain, I've had some success, and Dr. Velling can speak to this as well. He's probably had some patients in this situation where I've been able to help both the thoracic pain and low back pain. The thoracic pain part was typically, hey, this isn't the main target of what we're doing, but heck, if we can get good coverage of this area and get good relief, we've found another therapy to treat that pain. More commonly, we have patients that have totally separate areas of pain. low back and leg, but then they also have neck and radiating into their arm. And even in that scenario, spinal cord stimulator could treat both of those sources of pain potentially, but they have to be tested out separately because we have to stimulate separate anatomical positions within the spinal cord, one within the neck and then one within the mid-back. And so in that case, we try to prioritize what's limiting you the most and what has the most chance of success with the stimulator. And if it works really well, another trial can be done in the other area at a later time. And with some of the companies, they can all be connected to the same generator. And I know I'm talking a lot of specifics about the spinal cord stimulator, and I apologize about that. Next month, we'll go into a little more depth about the process of it. What are the indications for it? What is the process of having a trial, that testing period look like? And going through the whole, from beginning to end with the final permanent implantation that stays with you the rest of your life. So we'll talk more about that next time. I hope that answered some of your questions on that.
Yeah, that was great. Thank you guys so much. Okay, the last question that we're getting is, how do I get started? What do I do? Do I make an appointment? Do I just go get imaging first? So if one of you guys could just kind of maybe tell the process of what it looks like to see one of you and kind of get the ball rolling here.
Yeah, so the first thing is just give us a call. You can reach us on our, that's actually a really good segue. You can give us a call. You can email us. You can go to our website, www.genesismedwa.com. And you can always just give us a call and figure out, you'll probably see either Dr. Kinder, myself, Michelle, to help see you as a new patient, and we can just get the ball rolling that way. It's like I said, it's always going to start with figuring out what your history is, what your physical exam looks like, and if you have any imaging exams or what are some things you have tried. So yeah, like Maddie mentioned before, we don't exactly need referrals. So feel free to just give us a call. Did anyone else want to add anything to that?
Yeah, I'll go ahead and add to that. Yeah, I think the most important thing is just getting you here to be seen for an initial visit, and that way we can evaluate you, see what's been done in the past, because we obviously don't want to repeat things that have not been helpful for you, but just so that we can discuss with you what the problem is, how it's been affecting you, perform a physical exam, and then make a determination if we needed some additional testing or not. And that would tell us if there's, if we think that there's a likelihood that we can help you, or if we need to get some more information, get records from your other medical providers, or get you to some other type of treatment that either a surgeon or physical therapy or even chiropractic therapy that we think would be helpful. I mean, we try and do a comprehensive plan for you that can help you out. And so really just getting started is just get in here, get an appointment, and get seen for the first visit.
I think it's also good to mention that we actually book out pretty quickly, in that like we can get you in seen probably within that same week, or if not the following week. So you're not having to wait for months and months and months like at some of the other offices out there. So if it's something that's really, really bothering you, just give us a call. We can probably get you in pretty soon to be seen, and we'll get you the treatment that is best for you as soon as we can.
Perfect. Okay, well, that is all the questions that we've received. So I think we're going to wrap it up unless anybody else has anything else to say. Dr. Kinder, your microphone is on, so I just want to make sure I don't cut you off if there was something that you wanted to say.
Nope, just forgot to unmute.
Okay, sounds good. Well, thank you everyone for coming. We really appreciate you taking, whether it's your lunch break or you just finished your morning coffee. Either way, we respect all of those choices. Thank you for coming and spending your afternoon with us. And maybe we'll see you at the next one when Dr. Kinder really dives deep into spinal cord stimulation. And we hope you have a great rest of your day. Thank you, everyone.
Thank you all for coming and for listening to me drone on for a while. All right, everyone have a good day.
Bye.